nerves. The other nerves come off the spine. These are referred to as spinal nerves. There are 31 pairs of them. They are all mixed nerves. They're named for the point where they come off the spinal cord, so they don't have the descriptive names that the cranial nerves had. They supply all the parts of the body except for the head and part of the neck. There are 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 of lumbar, 5 of sacral, and 1 coccygeal. 7 vertebrae give rise to 8 pairs of cervical spinal nerves because each of the first 7 pairs, C1 through 7, exits the vertebral column above the vertebrae for which it's named. The last one, C8, exits below C7. So C7 has one above it and below it. And each pair of nerve exits is inferior, the rest of them inferior to the vertebrae which they are named. So it's, we have some cervical C1 through 8, T1 through 12, and from here, from C7 onward, there's a nerve underneath each vertebrae. Each spinal nerve is connected to the spinal cord through 2 roots, a ventral root and a dorsal root. The ventral root contains the motor or efferent fibers from the ventral horn motor neuron that innervates skeletal muscles. The dorsal root has sensory afferent fibers from sensory neurons in the dorsal root ganglia that are conducting impulses from the peripheral receptors. Both the ventral and dorsal roots are branched medially as rootlets, and then they join laterally to form the spinal nerve. Here are our rootlets joining to give us a root. Spinal nerves emerge from the vertebral column through their respective intervertebral foramina. The spinal roots become progressively longer superiorly to inferiorly down the cord. The lumbar and the sacral roots are very long and extend through the lower vertebral canal as a structure we talked about before, the quada equina, the horse's tail. Spinal nerves are quite short, 1 to 2 centimeters. They almost immediately after leaving the foramen divide into 3 branches: a dorsal ramus, a ventral ramus, and a meningeal branch. The dorsal ramus is the smaller, ventral is the larger. The meningeal is a very tiny branch that re-enters the vertebral column to innervate the meninges and blood vessels. There are rami communicantes, which contain autonomic nerve fibers and join the ventral rami in the thoracic region. Spinal nerve rami and their main branches supply entire somatic regions of the body from the neck down. The dorsal rami supply the posterior body trunk. The ventral rami supply the rest of the trunk and limbs. The difference between a root and a rami: roots lie medial to and form spinal nerves. Each root is purely sensory or motor. The rami lie distal to and are lateral branches of spinal nerves, and they carry both sensory and motor neurons. All the ventral rami except for T2 through T12 form an interlacing nerve network, which is called a nerve plexus. They are found in the cervical region, the brachial region, the lumbar, and the sacral. Only the ventral rami are going to form plexuses. And within each plexus, the fibers crisscross so that each branch contains fibers from several different spinal nerves. And the fibers from the ventral ramus go to the body periphery through several roots. That means that each limb muscle is innervated by more than one spinal nerve, so that if a spinal nerve was damaged, it would not cause complete paralysis. So we'll start with the neck, and in the neck we have the cervical plexus. It's for the first 4 rami, C1 through 4, form a looping cervical plexus, and most of its branches form cutaneous nerves. They are innervating the skin of the neck, the ear, the back of the head, the shoulders, and there are other branches that innervate neck muscles. Also has the phrenic nerve, which is a major motor and sensory nerve of the diaphragm, major muscles for breathing, and the phrenic nerve gets fibers from C3 through C5. If there are any Trekkies out there, this cervical plexus is the reason that Spock had the Vulcan neck pinch. He was supposedly able to shut off signals from the cervical plexus and cause unconsciousness. Irritation of the phrenic nerve causes spasms of the diaphragm. You used to call those hiccups, but now that you are anatomically educated, you should refer to them as diaphragm spasms. If both the phrenic nerves are severed or C3 through C5 of the spinal cord is destroyed, the diaphragm becomes paralyzed, and that leads to respiratory arrest. Patients, again, require a mechanical respirator to stay alive, and that respirator will force air into the lungs, breathing for them. The brachial plexus is going to the upper limb. It's formed by the ventral rami of C5 through C8 and T1. Gives rise to nerves that innervate the upper limb, and there are four major branches: roots, trunks, divisions, and cords. The roots are the five ventral rami, C5 through T1, that unite to form the trunk. The trunk is the upper, middle, lower, which are going to come together to form the division. The division is the anterior and posterior, and they are going to unite to form the cords, and there will be a lateral, medial, and posterior cord. So roots, trunks, and cords. And we can follow them in this flow chart. And I again recommend that you take a close look at all the figures in your text, as well as reading the text. The innervation of specific body regions, the cords of the branching plexus give rise to nerves of the upper limb. Five most important of those are the axillary, which innervates the deltoid, teres minor, and skin and joint capsule; musculocutaneous, which innervates the biceps brachii and the brachialis, coracobrachialis, and the skin of the lateral forearm; the median, which innervates the skin, most of the flexors, forearm pronators, wrist and finger flexors, the thumb opposition muscles; the ulna, which supplies the flexor carpi ulnaris, part of the flexor digitorum profundus, most of the intrinsic hand muscles, and the skin of the medial aspect of the hand, wrist, finger flexion. The radial innervates essentially all the extensor muscles, the supinator, posterior skin of the limb. Injuries to the brachial plexus are common. Severe injury can weaken or paralyze the entire upper limb. Injuries can occur if the upper limb is pulled too hard, stretching that plexus. So when a football player, a tackler, yanks the arm of a running back, or a blow to the top of the shoulder can force the humerus inferiorly, those things can stretch that plexus, causing damage. Injury to the median nerve makes it difficult to use a pincer grasp. That's the opposing the thumb and the index finger to pick up small objects. That can be seen in carpal tunnel syndrome. And in carpal tunnel syndrome, the median nerve is compressed. It's also, unfortunately, a frequent casualty injury from someone who tries to slash their wrist. And ulnar nerve is very vulnerable to injury. Severe or chronic damage to the ulnar nerve can lead to sensory loss, paralysis, and muscle atrophy. People with this damage to the ulnar nerve have trouble making a fist and gripping objects. The little and ring fingers become hyperextended at the knuckles and flexed at the distal interphalangeal joints, and it causes the hand to contort into what is known as a claw hand. This is the funny bone, where the nerve rests against the medial epicondyle that can make the little finger tingle. So the funny bone is not a bone, and hitting it is not funny. So here's the claw hand imaged. Trauma to the radial nerve has a different effect. It causes wrist drop, which is the inability to extend the hand at the wrist. Improper use of crutches can compress the radial nerve and impair its blood supply. Also, there is a thing known as Saturday night paralysis, in which an intoxicated person may fall asleep with their arm draped over the back of a chair or sofa edge that will cut off the blood supply to the radial nerve. And here is an image of hand drop. A little further down, the lumbosacral plexus and the lower limbs. The lumbar and the sacral plexuses have significant overlap. Fibers from the lumbar plexus contribute to the sacral plexus through the lumbosacral trunk, and the lumbosacral plexus serves mostly the lower limb, but also sends some branches to the abdomen, the pelvis, and the butt. The lumbar plexus arises from L1 through 4. It innervates the thigh, the abdominal wall, and the psoas muscle. The femoral nerve innervates the quadriceps and skin of the anterior thigh and medial surface of the leg. The obturator nerve passes through the obturator foramen. Remember that back from the skeletal system. And it innervates adductor muscles. The sacral plexus arises from L4 to S4. It serves the buttock, the lower limb, pelvic structures, and perineum. It has the sciatic nerve, which is the longest and thickest nerve of the body. It innervates the hamstring muscles, abductor magnus, and most of the muscles in the leg and foot. It's composed of two nerves, the tibial and the common fibular. And again, I encourage you to go through these tables as you read, or before or after you read. So homeostatic imbalances: when spinal roots of the lumbar plexus are compressed, you get problems in gait, which you would see walking or running. Other symptoms are pain or numbness in the anterior thigh. That femoral nerve serves the prime movers that flex the hip and extend the knee. So damage to that can happen because of a herniated disc. If that obturator nerve is impaired, the person would experience pain in the medial thigh. Sciatica is a relatively common problem. It's characterized by stabbing pain radiating over the course of the sciatic nerve. It can be injured by a fall, by a herniation of a disc, or a poorly placed injection into the buttocks. So when you learn to give intramuscular injections, this is one of the things you'll be instructed to avoid. If the nerve is transected, the leg will become useless because it cannot be flexed, because the hamstrings become paralyzed. Foot and ankle cannot move at all, so the foot drops into a plantar flexion, a condition called foot drop. Recovery from sciatic nerve injury is usually slow and incomplete. If the lesions are below the knee, then the thigh muscles are spared. If the tibial nerve is injured, paralyzed calf muscles can't plantar flex the foot, and a shuffling gait is the result. The anterior lateral thorax and abdominal wall are innervated by ventral rami of T12. T1 through T12, I believe that should be, not T12 through T12. They are intercostal nerves that supply the muscles of the ribs, the anterior lateral thorax, and the abdominal wall. They give off cutaneous branches to the skin along the course. There are two special thoracic nerves. There's a tiny T1, and T12 is a subcostal nerve. The back is innervated by dorsal rami through several branches. Each branch innervates a strip of muscle and skin in line with where it emerges from the spinal cord. And that brings us to how the skin is innervated. And an important way that the skin is innervated gives rise to what are known as dermatomes. Dermatomes are areas of the skin that are innervated by cutaneous branches of a single spinal nerve. All of the spinal nerves except C1 participate in the dermatomes. The extent of spinal cord injury can then be ascertained by its effect on these dermatomes. Most of the dermatomes overlap with each other, so destruction of a single spinal nerve would not cause complete numbness. And they are mapped out here with the nerve that innervates them. And front and back. The joints, to remember which nerve a synovial joint uses, you can look at those dermatomes. Hilton's law states that any nerve serving a muscle that produces a movement at a joint also innervates that joint and the skin over that joint. And I believe that ends our discussion of spinal nerves. All right, we're moving right along.